So I'm Marlieke, and Jeroen Hassler already explained the InSup-C project this morning and the structure of it. And I'm going to describe the results from the group interviews and the patient and family caregiver interviews. So we did group interviews with 19 groups and 133 professionals. And in the group interviews, we asked professionals how they provided integrated palliative care in practice. And those group interviews were actually, they consisted of the initiatives that we selected for the InSup-C project. And also, we did interviews with patients and family caregivers, 175 patients and 90 family caregivers. And we asked them which professionals were involved in their networks, care networks, and how professionals responded to the needs of patients and family caregivers. And I'm first going through the main point from the group interviews. First, the important point was timing, because the integrated palliative care initiatives try to integrate palliative care as early as possible. But in many cases, they depend from referrals by other professionals, and these have difficulties with starting palliative care, when to start palliative care. They often have not enough knowledge about palliative care or the added value, or rather focus on cure, for example. And another thing was also that patients and family caregivers need to accept palliative care before it can be integrated, before professionals can have conversations with them about the end of life. So strategies that are used by professionals in the initiatives were mainly focused around building relationships with professionals, for example, by visiting multidisciplinary meetings or doing ward visits or doing shared care. And this helped them to establish trust in palliative care and to know what it is about and when to integrate it. They also built relationships with patients and family caregivers because, for example, in non-cancer diagnosis, it is very difficult to know the prognosis. So building relationships helped professionals to know when, what kind of needs patients and family caregivers have, and what the right moment is to start end-of-life conversations. And standard ways for timing palliative care were rare in our initiatives. Jeroen Hassler also explained that. The next point was multidimensional care. And one way to provide multidimensional care was, of course, seeing patients and family caregivers with a holistic eye. And professionals in the initiative are trained for that, and they have skills to recognize needs of patients. And also by building those relationships, they were able to know what needs were. And multidisciplinary teams were also ways to provide multidimensional care. But in many cases, professionals missed some of the disciplines. For example, in Hungary, they say we are psychologists in our way, because they need to be creative to also have attention for psychological needs, for example, because psychologists were difficult to find. And also some initiatives have established fruitful relationships with several disciplines in order to enhance access to patients to multidimensional care. For example, heart failure collaborations. The third point is continuity in out of hours, and this was often a vulnerable element in care provision. And planning care in advance was one way, that is also central in palliative care, of course, but it was difficult sometimes because planning care in advance also depends on early referrals. And another way was that professionals gave their phone numbers to patients to be available at all times. Another way was being available for other professionals by means of advice lines to provide care during our hours. And also forged way was that agreements were made to ensure continuity in out of hours. For example, agreements with ambulance services, so that patients can be left at home when they have written down that they don't want to be admitted anymore. The last point from the professionals was coordination of care. And most initiatives made use of multidisciplinary meetings to coordinate care, but it often only concerned the core group of the integrated palliative care initiative. And that also applies to information transfer. Multidisciplinary meetings were a good way to transfer information, but formal ways, for example by systems, computerized systems, were rare. And only one initiative in the UK had an ICT system which was accessible throughout the whole network for hospitals, GP practices, the initiative itself. And initiatives differed in the extent to which they coordinated care. Some took over the whole care, others provided shared care with regular care professionals, and there were also initiatives that only advised other care professionals. Then I will go to the patients and family caregivers' perspectives. Also 4 points were highlighted here. And the first point was relations and person-centered care. Patients and family caregivers wanted to establish relationships with professionals and therefore see the same professionals on a regular basis. However, although they often had not known palliative care professionals for a long time, they very much appreciated person-centered care these professionals provided. And person-centered care meant, for example, being interested in the person, not only the illness, taking time to talk about non-medical subjects and making jokes, for example. The third point is information provision to patients and family caregivers. This was also very important because it helped respondents to internalize what they had experienced in their illness trajectory. And it also gave them trust and could relieve feelings of uncertainty. And while respondents sometimes had difficulties with receiving the right information at the right time from regular professionals, many praised their palliative care professionals for being honest in providing information and taking time to explain difficult questions. And then the third point is information transfer between professionals. This was an element that could relieve or worsen trust in professionals, and many respondents said that they did not know how professionals work together, but in practice they could experience whether information transfer was going well or not. And some patients really had the impression that care was well organized in some little networks between professionals, because they saw that professionals knew each other. And our data suggests that these little networks concerned integrated palliative care initiatives. Because I think I forgot to say that in the interviews we did not explicitly ask patients and family caregivers how they experienced care provided by the integrated palliative care initiatives, but we asked their experiences about care in general. But through the examples patients and family caregivers gave, we could see, this is about professionals who are involved in the integrated palliative care initiatives. Within little networks, it seems that information transfer was going well, but beyond these networks, information transfer was often deficient. And this was mainly focusing around the hospital institute and among professionals from different organizations who didn't share electronic patient records. The last point from the interviews was care management and access. And a crucial element for respondents was having someone to go to when having needs. And many patients and family caregivers also had a phone number which they could call, and this gave them trust. And a number of respondents also appreciated coordination provided by the Integrated Palliative Care Initiative. So some patients had a kind of case manager who coordinated between different professionals, And other patients, they experience very smooth transitions between, for example, hospital and home stay. However, access was also a problem for many patients. In the UK, many patients appreciate daycare therapies, but these are temporary, so could not meet all their needs throughout the whole illness trajectory. And in Hungary, many patients without cancer, for example heart failure and COPD, didn't have access to all hospice care, the whole package. So in general, their experiences were worse from those of cancer patients. And as Jeroen also said this morning, most of the initiatives consisted of care for cancer patients, and also in the interviews, the majority was cancer patients. So as a conclusion, we see that the integrated palliative care initiatives mainly consist of passionate professionals, and they put large efforts in building relationships both with patients and professionals, and they do that in order to integrate palliative care as early and needless as possible. This works well within certain specialist groups and provides access to mainly cancer patients, but the non-cancer groups still stay behind. And standardized way to start palliative care or transfer information are rare. And also for patients and family caregivers, when they are lucky to have access to the good care from the integrated palliative care initiatives, they really appreciate the comprehensive and person-centered approach of the initiatives, but also beyond the initiatives, the care is not always very well. And of course, there are many professionals beyond the initiatives who are also providing very good care, but this was our main finding. So in order to bring integrated palliative care forward at clinical level and increase access for non-cancer patients, initiatives should keep what they are already doing, because they do many good things, but we need more frameworks, as David Curl also said this morning, and education to spread palliative care to other disciplines that still stay behind. And this does not only require efforts from the palliative care initiatives, but also from other mainstream professional groups and also policymakers to make this possible at system level. Thank you.